In next 5 to 7 minutes, I will be discussing a paper published in the Green Journal, impact of radiation dose to the immune cells in the unresectable stage 3 non-small cell lung cancers in the durvalumab array. Locally advanced lung cancer is the commonest occurrence for the lung cancer. The Pacific trial has proved and shown that the addition of 1 year of durvalumab to the CTRT as a consolidation improves the outcomes, and it is a new standard of care. Initial RTOG 0617 trial comparing the dose escalation up to 74 gray showed that there was a poor outcomes with the escalated dose of 74 gray. The authors had a hypothesis that the higher dose to the circulating immune cells and the depletion of the anti-tumor immune cells were responsible for the poor outcomes. They also gave an idea or a concept of the estimated dose to the immune cells or a EDIC, and they showed that the EDIC of more than 6 gray impacts the overall survival by a function of around 8% per gray additional dose to the EDIC. However, the similar data in the durvalumab treated patients is not available, and the current paper tried to see what is the impact of EDIC on the outcomes in a durvalumab treated patients. So this is the model to calculate the EDIC given by the GMAT. It calculates the mean heart dose, mean lung dose, and the integrated total dose volume. That is, they try to see what is the dose received by the integrated body or a scanned body for a particular patient, and they take into the account number of fractions which are being planned and the weight of the patient. So coming to the materials and method for the present study, this is a retrospective study done between 2017 to 2020. They enrolled 100 patients treated of stage 2 and stage 3 unresectable tumors. All the patients were planned for a CTRT followed by the durvalumab. They included patients who received at least one cycle of durvalumab. Also, they included the patients who have completed more than 25 fractions of radiation. Because to calculate the EDIC, you need to have at least 25 fractions of treatment to be given. All patients were planned with 4D CT, and they were treated with either 3D CRT or IMRT. The primary endpoint of the study was overall survival, and the secondary endpoint was progression-free survival and the local regional control. They also had an additional exploratory endpoint of time to develop brain metastasis. EDIC was calculated based on the formula given by GMAT, and the TPS parameters were taken for the calculation. They divided the patients into two groups, EDIC of more than 6 gray versus EDIC of less than 6 gray. 54 patients had received EDIC more than 6 gray, and the remaining had received less than 6 gray. They calculated for the statistical analysis for the impact. They calculated the EDIC both as a categorical variable with a 6 gray more or less, and continuous variable in the function of 1 gray. So this is the baseline parameters. So all parameters were matched except for a few parameters like a stage. EDIC more than 6 gray had a higher stage 3 disease as compared to EDIC less than 6 gray. Also, the mean GTV volume was significantly high in EDIC more than 6 gray. And the median number of durvalumab cycles were higher in the EDIC less than 6 gray group. Less than 6 gray group. This they showed that this is because of the more patients in the EDIC more than 6 gray group had a progression on durvalumab, so they had to discontinue the durvalumab. So the median follow-up for the group was 23 months. The mean dose to the heart was 10.5 gray, lung was 13.7 gray, and the total body was around 9.5 gray. At last follow-up, 29 patients had died. 27 of these had a disease progression, and for 2 patients the cause was not a disease progression. Brain metastasis was found in 11 patients, out of which the 9 patients had a EDIC more than 6 gray. So coming to the survival outcomes, all primary and secondary endpoint outcomes, the median OS, PFS, local regional control, or a time to brain metastasis was shorter in EDIC more than 6 gray group as compared to EDIC less than 6 gray group. So this is the survival curves showing the same difference. On the multivariate analysis, the EDIC more than 6 gray group was significantly impacting the overall survival, local regional control, and the progression-free survival, both either calculated as a categorical variable or as a continuous variable. So, with this paper, the incidental radiation dose to the immune cells in the peripheral blood partially negate the benefit of immunotherapy. The radiation acts as a double-edged sword. So it has an immunostimulatory effect also by exposing the antigens, as well as the immunosuppressive doses effect also by suppressing the immune cells in the blood. The higher EDIC predicts the worse OS, PFS, and local regional control, even after accounting for the other prognostic variables. The brain metastases are reduced as compared to the historical cohort. However, it is still one of the most common site of extrathoracic progression. This trial also gives a new OAR for the radiation oncologist, in which try to estimate the dose to the as a EDIC and try to optimize based on the EDIC to reduce it to less than 6 gray, which is associated with better survival outcomes. Thank you.